Hello and welcome. Today we're delving into a complex and often traumatic condition affecting the urinary system, ureteral avulsion. This is where the ureter, the tube that carries urine from the kidney to the bladder, is completely or partially torn away from its attachments. We'll explore the causes, symptoms, diagnosis, treatment, and more, providing a comprehensive overview of this significant medical issue. So, what causes a ureteral avulsion? The primary culprit is trauma. This can be from a blunt force injury, such as a car accident or a fall from a height, or a penetrating injury, like a gunshot wound or a stab wound. Iatrogenic causes, meaning injury caused by medical intervention, are also significant. These can include complications during surgical procedures like ureteroscopy, laparoscopic surgeries, or even open abdominal surgeries. The relative weakness of the ureter at certain points, like its junction with the kidney or the bladder, makes it more vulnerable to avulsion during these events. Let's discuss the pathophysiology. When the ureter is avulsed, the flow of urine from the kidney to the bladder is disrupted. This obstruction leads to a buildup of urine in the kidney, a condition called hydronephrosis. The pressure from the accumulated urine can damage the kidney over time. Additionally, the avulsion site can bleed, leading to hematoma formation. Urine leakage into the surrounding tissues causes inflammation and potentially infection, further complicating the situation. Depending on the severity and location of the avulsion, different mechanisms may predominate. For example, a complete avulsion at the ureteropelvic junction, a UPJ, immediately stops urinary drainage, while a partial avulsion near the bladder may cause persistent leakage and inflammation. Regarding epidemiology, ureteral avulsion is thankfully a relatively rare injury. It's more commonly seen in cases of significant trauma, particularly in high-speed motor vehicle accidents. Iatrogenic injuries can occur in any age group undergoing urological procedures, but the specific incidence depends on the type and complexity of the surgery. There are no strong indications of gender or racial predispositions to ureteral avulsion itself, but of course, the underlying risk factors, such as participating in high-risk activities or requiring complex surgical interventions, can vary. The signs and symptoms of ureteral avulsion can be subtle or dramatic, depending on the severity and mechanism of injury. Common symptoms include flank pain, which can be intense and localized to the affected side. Hematuria, or blood in the urine, is frequently present. Patients may also experience nausea, vomiting, and abdominal distension. In cases of urine leakage, swelling and tenderness in the abdomen or flank may be evident. If the avulsion is unrecognized and untreated, complications such as fever, signs of infection, and even sepsis can develop. Diagnosing a ureteral avulsion often requires a combination of imaging studies. A CT urogram is the gold standard, providing detailed images of the kidneys, ureters, and bladder. This allows visualization of the avulsion site, urine leakage, and any associated injuries. Retrograde pylography, where contrast dye is injected directly into the ureter, can also be used to assess the extent of the injury. Ultrasound may be helpful as an initial screening tool to detect hydronephrosis, but it's less sensitive for identifying the avulsion itself. The patient's clinical history and physical examination findings are also crucial in guiding the diagnostic process. While there aren't rigid classifications for ureteral avulsions in the same way as some other medical conditions, they can be broadly categorized based on the location of the avulsion, e.g., ureteropelvic junction, mid-ureter, ureterovesical junction, and the extent of the injury at complete ves, partial. Some classifications might also incorporate the mechanism of injury as traumatic ves iatrogenic. The categorization influences the treatment approach and prognosis. Treatment and management of ureteral avulsion depend on several factors, including the location and severity of the injury, the time elapsed since the injury, and the overall health of the patient. Immediate goals are to stabilize the patient and prevent further damage to the kidney. Initial management often involves placement of a nephrostomy tube, which drains urine directly from the kidney, relieving pressure and preventing further hydronephrosis. Surgical repair is usually necessary. This can involve reimplantation of the ureter into the bladder's ureteroneocystostomy, ureterostomy connecting the two ends of the ureter, or, in more complex cases, using a bowel segment to bridge the gap. Robotic or laparoscopic techniques are increasingly used for ureteral reconstruction, offering minimally invasive approaches. The choice of surgical technique depends on the specific circumstances of each case. Preventing ureteral avulsion focuses on minimizing the risk of trauma and exercising meticulous surgical technique. Safe driving habits and adherence to safety regulations can reduce the incidence of traumatic injuries. Surgeons should be aware of the potential for ureteral injury during urologic and abdominal procedures, taking precautions to avoid excessive traction or manipulation. Careful placement of instruments and a thorough understanding of the anatomy are essential for preventing iatrogenic injuries. The prognosis for ureteral avulsion depends on the promptness and effectiveness of treatment. Early diagnosis and surgical repair generally result in good outcomes with preserved kidney function. However, delayed diagnosis or incomplete repair can lead to complications such as ureteral stricture, chronic pain, recurrent infections, and even kidney loss. Recent advances in minimally invasive surgical techniques, including robotic surgery, have improved the precision and outcomes of ureteral reconstruction. Researchers are also exploring new biomaterials and techniques to enhance ureteral healing and prevent stricture formation. Thank you for joining us for this discussion of ureteral avulsion. We hope this information has been helpful. Consult your physician for any medical advice or diagnosis.